Next up is Josh Lemieux. Josh is the Chief of Staff for Eric Dishman, who's an Intel Fellow. I've known Josh for many years. I know him when he worked at the Markle Foundation. He has more than 18 years of experience working in patient engagement, and he's passionate about that, and he's going to share some remarks focused on patient engagement with us now. Welcome, Josh.
Thank you, Joe. And for your sake, I'm sorry that Eric's not here. He's a very powerful speaker, and he has a very interesting story to tell. The good news is he's fine. He just has a passing illness with his stomach that prevented him from flying, and he does need to be careful because he is immunosuppressed following a very successful kidney transplant, and that followed a 21-year or very arduous journey through the healthcare system, and he does a very artful job of weaving that story into a vision of personal health in the 21st century. And I can't do that exactly the way he does it, but I can say that he is cancer-free today. He has a tremendous, ridiculous stamina, very hard to keep up with, and I should know because it's my job to try. So today I'll work on showing you his vision, and I think it's a vision that probably if you're at this conference, you're working on some component of it, and you have ideas that could advance it. And so hopefully it resonates, and if it doesn't, let me know. But don't do that right now because I'm trying to concentrate a little bit up here. The important part of this vision is that it's not just something that Eric has outlined as a result of his journey through the healthcare system. It's a result and a response to global healthcare challenges, mega challenges that we all face. And so those challenges we've kind of coalesced into three very, very serious, almost arithmetic problems. We have global aging. We are going to have 2 billion people over 60 at the mid-century point. This is unprecedented. We're going to have more older people than younger people. Never before in human history have we had that. As we know, as people get older, they have more chronic conditions and comorbidities that are more expensive and require more care. The problem is that we have a worker shortage as well. More than 4 million today, or at least a few years ago, as measured by the World Health Organization. And that's only going to get worse because the baby boom generation has not even really hit yet. And we've done things like expand Medicaid in this country. And so there's a serious access issue. And we still have the problem of rising healthcare costs. If we look at a 50% increase from the beginning of this decade projected through the end, and we know that even though there has been some improvement of the cost curve over the last 4 years or so in the United States, the pressures on creating healthcare inflation are very powerful and they're very hard to reverse. And most importantly, they're unsustainable. Now, if you think about these three problems, they're huge challenges even if we had a very efficient healthcare system. Even if we had a healthcare system was service-oriented and optimized for great outcomes. But as we all know, that's not the healthcare system we have, and worldwide. In this country alone, we waste $750 billion a year on care that is not helping people be healthier. It goes into the economy and it feeds the GNP, but it's not the best way to spend money as measured by the IOM. And so these are very serious problems that all intertwine that we need to deal with. Now, fortunately, there are some other trends that can help us have tools to deal with some of these problems. We call these other mega trends for global health. Payment reform is certainly one of them. We're dipping our toe in the water of shifting from a volume-based, fee-for-service type of model of healthcare reimbursement to a more value-based system. We also have very significant public investments worldwide. Meaningful use is the flavor in this country. There are other flavors in other countries where the governments are intervening in the healthcare economy in order to stimulate the digitization of healthcare information, and that's a necessary component to build upon. We also have more engaged patients, and that's been a big vision of Joe's center and this event. Certainly something that I've worked on in previous jobs at WebMD and Markle and even the Discovery Health Channel when that launched, and Mayo Clinic. This is a very important trend, and it is fueled by advances in computing. These things go together. More engaged patients have better tools. They have mobile, they have social networking, they have apps, they have gadgets, wearables, Internet of Things, and it all goes up into cloud, and then they can benefit from big data analytics. They can participate, contribute their data to new discoveries. And so these are important tools that we have in order to combat some of these very difficult challenges in healthcare. So Intel's vision on this is depicted on a pretty simple little diagram that Eric drew on a napkin more than a decade ago. You basically have two vectors on this diagram, the quality of life and the cost of care. And the whole idea behind this is that we want to shift the healthcare system much more optimized toward a higher quality of life at a lower cost, and that means taking care into the home. It means taking care and units of care and touch points of care, healthy behaviors into the home, the car, the workplace, the playgrounds. And so that means evaluating all the units of care, optimizing a lot of technologies, computing stacks if you're at Intel, but workflows if you're in the clinical space, to try to move the population toward the upper left of this diagram. And the beauty of that is that there's lower skills required if we have people living independently in order to monitor them. And there's also technologies such as sensors, wearables, and things like that that can keep track of things, like Michael mentioned with some of those excellent examples. And so when Eric wanted to inspire our team to work on technologies that fit this diagram and help push things in the right direction, he wanted to describe a few experience pillars of what this would be like for those of us in the healthcare system, a healthcare system that we think matches the modernity of technology, the march of improvements of technology. And so those experiences he grouped into three buckets here. And the first one is care networking. Now, a lot of people call this care coordination, and that's fine. We just have a different term for the same concept, which is shifting from solo-based, small practice, independent practitioners where the patient goes, and that's where a single visit, episodic care, somewhat sporadic, to a team-based model where across IT systems and across organizations, a variety of people, including the patient, including the family, including the neighbors, including non-traditional healthcare workers, are part of this team. Also, care anywhere, which some people call mobile health, mHealth, things like that. We're talking about the generation of technology that enables people to reach out and connect to services wherever they are, whether it's their car, their home, et cetera, the workplace. And that is a whole stack of computing technologies, and it's a whole culture change that we're experiencing in all other examples. For example, Uber, as Michael said earlier. And we need to bring that to healthcare in a trusted way. The third experience pillar is care customization, and a very broad concept of that, which I'll unpack in a little bit. But basically, we're talking about moving from making decisions in healthcare based on population research and clinical trials to actually zeroing in on the individual right down to the molecular level, the codes that live within our genes, our genome, our exome, our proteins, and customizing therapies based on that very complex and very high volume information. So what are the culture changes, the capability transformations that we have in order to make these pillars a reality in this century, actually in only a few years? So for care networking, I'm just going to mention a few. You probably have other ideas. But it really starts with the care model. It starts with having a more proactive approach. It's the kind of the ACO model or primary care medical home model. We want to shift to a more proactive approach that emphasizes not a doctor coming in and saying, well, who am I seeing today? Who's coming in? Who's going to come in last minute? But who should I be seeing today? Who should I be seeing next week? Who should I be following up on? Who has higher risk? Who has some complications that are going to happen? We just want to make sure we delay them as long as possible and improve that quality of life. We want to skill shift, as I mentioned earlier, to patients and families and give them some tools online that they can use in order to digest information, make decisions, and things like that. Have coaching, have touch points with maybe not a nurse or an NP or a doctor every time, but a coach. We want to change this way that software works, and this is going to be a very difficult evolution based on the EMR tools that have market share today, but change them from transaction tools to more care coordination tools. And obviously that shift is happening, but it's very, very difficult with installed software. So instead of just saying this patient got this diagnosis and then this drug here, and it was filled at this pharmacy, and it was paid for by this insurer or PBM, something that helps a team make decisions. And also moving clinical support in the same direction. So it's not just, say, one doctor looking at a differential diagnosis tool or a drug interaction tool, but actually something that the team can share and share their expertise and perspectives through the software to make better decisions for the patient and include the patient in those decisions. And then lastly, start to shift the way that we measure quality so that every clinician, every family is almost part of a learning organization where they get continuous feedback loops, and they can figure out that, instead of sending this report to this organization, another report to this other organization, another report to a few different government agencies, to have an infrastructure where they can see the data, they get it more real time, and they can make process modifications and improvements based on a continuous learning approach. So unpacking care anywhere, and this is something I'm sure has been discussed and will be discussed throughout this conference, but it starts really with working on standards and trust frameworks for what Eric calls trusted mobility for clinicians and patients, and that means having tools and standards and protocols by which we can make sure that these connections that are increasingly mobile are trusted. So, for example, if a patient has some type of remote monitoring, biosensing equipment in their home, having a trust framework by which the provider that can consume some of that data can understand that that's a trusted device, it's on a trusted network, it's been calibrated, it shows decent trend data that you can help make some judgments on. We definitely need to shift to telehealth. That movement has been slowly building for 20 years. It works in many settings. It makes sense given the terrible shortage of access in especially rural areas, but many different use cases. And reimbursement is coming along, but it's been terribly slow. We need to shift remote patient monitoring so it's not necessarily a dedicated device that you have to buy or receive and install in your house and pair with things, but move this into everyday devices that we're all carrying around with us, laptops and tablets and phones, etc. That movement is happening. It just requires containerization of data and some security protocols to separate health information from other parts of our clouds and our devices. We need to shift from visit-based monitoring to more on-the-body monitoring, like the sensors that Michael talked about, and even in-the-body sensing, which is coming along as well. And so just a nice example of this is Intel recently worked on Parkinson's with the Michael J. Fox Foundation. We have a very significant interest in that particular perplexing disease because Andy Grove, a very famous Intel executive, only the paranoid survive guy, he is living now with Parkinson's, and he has turned us on to a new means of research which I think ultimately holds a lot of promise. So we gave Parkinson's patients in this trial a watch to detect motions and things like that, tremors that people have with Parkinson's. Now, if you compare that to the current patient or the patient for the last several decades of Parkinson's, they come in every 6 months or so to a doctor's visit and kind of recall how their symptoms are going. Maybe 3 weeks ago they were worse than they are now, and it's very subjective. It's an incredible data poverty, really. It's sporadic and not very well measured data. Well, this watch that we gave these subjects, it was measuring 300 measurements per second. So that's a lot of data because there's a lot of seconds in a day. And I have to believe that somewhere in all that data are some trends and insights that will unravel some of the mysteries of Parkinson's. And if nothing else, it ought to be able to show how certain types of patients are responding to certain medications, and help us have a better means, new paradigms for measuring quality through wearable devices and big data analytics and research discovery. Lastly, Eric has a little presentation where he takes a portable ultrasound, he sticks it on his new kidney, and he shows an image of it on the screen, while on a separate screen or a split screen is his doctor, and he's having a live Skype chat showing an image of a portable ultrasound plugged into a mobile phone. Now, this isn't an FDA-approved use where a patient is using such medical equipment, but it shows how medical-grade capabilities are now being integrated into everyday devices. You know, the high-end devices that many different organizations are working on, and plug-ins will be able to bring those capabilities to the market, and we clearly need a regulatory framework to handle this, but not stifle this incredible innovation, because the footprint of technology in medical imaging, for example, or medical monitoring is getting so small it can be reduced into tools that we use for all our other things. Care customization is a very broad concept, the way that Eric likes to talk about it, and it's not just the genomics, precision medicine that's so exciting and that Michael also gave great examples for. He really starts it with a passion of his, which is the incorporation of individual goals into care plans. Now, current medical record systems don't even have a location for, hey, what's the patient really want? You know, he tells this very interesting story about how when he was going through chemotherapy, he asked for more continuous lower doses so that he could go ski, because he really likes to ski. And it turns out that he didn't know it at the time, but that type of approach to chemotherapy actually has its place in the treatment regimens for cancer. You know, it was just an example of a patient, a very proactive patient, trying to put his own goals into a care regimen. And so work on record-keeping system, team-based software that take advantage of what the individual wants is an important part of customizing care. There's also this area of what we call omics, genomics, proteomics, you know, the study of protein, taking a look at the individual at the very molecular level and trying to determine the very tiny variations in DNA that result or create the roots of disease susceptibility. And this is a very exciting area. People say that, you know, this revolution has been coming for several years, since it took, you know, $100 million a decade ago to sequence one person's whole genome. Today it's getting down to about 1,000, and Intel works very hard on the compute power and are able to make that happen. It's actually advancing faster than Moore's law. And shifting to a more predictive model, using this information to say, you know, what are the risks and what can be done to modify those risks. You know, Eric likes to say, you know, when he had cancer, when they were trying to determine chemotherapy agents, you know, let's experiment on an avatar in software, not on an actual individual. Let's model this based on these predictive modeling tools. And this is an important shift of 21st century that's going to, the technical capabilities are going to come faster than perhaps some of our policy frameworks or our imagination or our worker training. And so in Eric's particular case, it turned out that the chemotherapy agents that he was on over the years were not destined to help him, and they didn't know that until they did a whole genome sequence and they sequenced his cancer cells. And it turns out that they put him on a different medication, actually an older medication for pancreatic cancer, and were able to declare him cancer-free and make him eligible for a kidney transplant that literally you know, saved his life, because he was very close to kidney failure when that came through. So, poster child for precision medicine, for care customization, and he now wants to gear Intel resources and the rest of the ecosystem to scaling those capabilities. You know, what we've worked on at Intel is a goal to take a whole genome sequencing process, the analytics and analysis that it takes among teams to figure out what to do, to the identification of an actual precision medicine treatment to try on an advanced cancer patient, and take that time and shrink it to a day by 2020. So just 6 years away, 5 years away. Currently, that takes about a month, even in the best case, at the best cancer centers. So that's a very ambitious goal. But we think it's important to advance that. And then the vision is to not only have this process of whole genome sequence analysis, precision medicine identified, but to then combine it with this vision we had in the Parkinson's project, and many other people have, where you send them home with some type of monitor or sensor that tracks how well that the treatment works, and we can see what the response is. So it's a new method of discovery. And then lastly, the technology is moving very fast. There will be shifts and experiments to artificial organs, artificial kidneys. The kidney is a filter. Some days somebody will figure out how to use synthetic materials to build on that, and synthetic tissue and things like that. And so that's an area which is also advancing faster than some of our imaginations. So just to close, I'd like to have a few challenges to help make these experience pillars happen. I'll just go through them quickly. It really starts again with the care model. How do we pay for care? Can we incentivize for prevention, for early detection, for behavior change? Again, ACOs are dipping a toe in the water, but we need to continue the pressure on providers, on policymakers, to keep this drumbeat going, because it's incredibly, incredibly important. We need to place shift and skill shift and be open to new roles in healthcare, including those of the family, of coaches, of caseworkers, et cetera, and do that whenever possible, and measure their effectiveness. They shouldn't be off the hook for measurement just because they're non-traditional. That's what we need to do. We need to invent new kinds of care workers in order to do this important work and put people up in the upper left of that diagram I had. And we, let's see, there we go. We need to use technologies like telehealth and other things, and new software to link up teams and healthcare systems. On Care Anywhere, we need to broaden our views, take a look at our workflows, enable them outside of clinic walls. We need to improve the standards and build trust frameworks. Intel's done a lot of investment in Continua. This is important work in order to create protocols that can be trusted over networks. We need to combine forces. I was very involved in the Blue Button movement, for example, in the early days. And we need more rallying cries to free up data and give patients the tools and empowerment that they need to contribute to those global challenges for healthcare. And we need to measure. You know, Eric likes to say we should be measuring units of care and where they occur. That's not in the current system, but was care delivered in the safest, least restrictive, preferred setting that the patient chooses? That could be one of the measurements that we take. Where is the unit of care taking place? How do we compare when it's occurring in the home versus when it's occurring in the clinic? On care customization, there are these technological challenges. There's so much data when you do a whole genome sequence that it requires enormous data centers and networking and things like that. And so we're looking at architectures that will enable that. So these are very interesting problems and kind of problems that Intel engineers love to work on, and the ecosystem will continue to improve that, probably faster than Moore's Law. But there are also financial issues. You know, how do we pay for precision medicine? How do we pay for predictive modeling and interventions that might result from that information? A lot of this stuff is not yet proven, and it could be very expensive. So we need to work through that as a society. We also need to train bioinformaticians and clinicians and even patients about what to do with this data. And a lot of this is cultural, the social covenants, the consent, the privacy, the ethics. Genetic information is different from other health information. All needs to be kept very securely and be safeguarded. But because it involves more than one person's decision, right? This is family information, basically, passed on. And we need to create frameworks that enable that trust. So I'll leave you just with a quote from Eric. He says that this is an imagination problem. It's not a technology problem, even though we're at a technology company. And fortunately, at a great event like this, you have a lot of imaginations out there that contribute to this vision. And so I really thank you for letting me share a little bit of it with you here today. Thank you.